Today, we're going to continue with EKG Interpretation, Part 2. We'll cover three key topics: PR interval, QRS Complex Abnormalities, and ST segment/T wave changes. And don't forget, nurses who can read EKGs are truly impressive professionals. In the following, you will learn about PR interval. Understand different types of heart blocks caused by delayed conduction from the atria to the ventricles. QRS complex abnormalities. Recognize abnormal ventricular conduction, such as bundle branch blocks or ventricular hypertrophy. ST segment/T wave. Identify ECG signs of cardiac ischemia or infarction, ST elevation or inverted T waves. Examples and summary. Reinforce your knowledge through real-life ECG cases. We'll learn how delayed conduction between the atria and ventricles shows up on an EKG. This helps us recognize different types of heart blocks, an essential skill in critical care. PR interval is how long it takes the signal to go from the atria to the ventricles. If it's too long, over 0.20 seconds or 5 small boxes, it means the signal is delayed at the AV node. This is called AV block. Normal range, 0.12 to 0.20 seconds, 3 to 5 small boxes. In first-degree AV block, the PR interval is consistently longer than 0.20 seconds, more than 5 small boxes. The signal still gets through, just slower than normal. It's usually asymptomatic and found incidentally on ECG. First-degree heart block is the mildest form. The PR interval is long, but every P wave still makes a QRS. It usually causes no symptoms and needs no treatment. Mobitz type 1, Wenckebach. In this rhythm, the PR interval gets longer and longer. Then suddenly, a QRS is dropped, the ventricle doesn't contract. Just remember: longer, 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 drop. Mobitz type 2. The PR interval stays the same, but some QRS complexes are suddenly missing. Example: in 2:1 block, every second P wave is not followed by a QRS. Think: steady, then drop. Steady, then drop. Mobitz 2 is dangerous and may progress to complete heart block. It often requires pacemaker placement even if asymptomatic. Third degree, complete, heart block. P waves and QRS complexes are completely dissociated. Atrial and ventricular rhythms are independent. This is a medical emergency requiring immediate pacing. Short PR interval, WPW syndrome, Wolff-Parkinson-White. There's an extra shortcut, extra pathway, in the heart. It bypasses the AV node, so the signal moves too fast. This makes the PR interval shorter than normal. Look for a delta wave, a slurred upstroke at the start of the QRS. Wolff-Parkinson-White, WPW, syndrome involves an extra electrical pathway in the heart, leading to episodes of fast heart rhythms. Common symptoms include sudden palpitations, dizziness, fainting, chest discomfort, and shortness of breath. The most frequent arrhythmia is AVRT, while atrial fibrillation with WPW can be life-threatening due to the risk of ventricular fibrillation. For stable patients, vagal maneuvers or adenosine may stop the arrhythmia. Unstable patients require synchronized cardioversion. Verapamil and digoxin are contraindicated in WPW with atrial fibrillation. QRS complex. This part of the ECG shows when the ventricles contract. It's usually the tallest part of the waveform. We'll look at its shape, width, and what it tells us about the heart's rhythm and conduction. QRS complex abnormalities. Normal QRS, 0.06 to 0.10 seconds, 1.5 to 2.5 small squares. Wide QRS, greater than 0.12 seconds, suggests delayed ventricular conduction. Common causes: Bundle branch block, BBB. LBBB, wide QRS, deep S in V1, tall R in V6. RBBB, M-shaped, QRS in V1, wide S in V6. Ventricular rhythms, like VT. Hyperkalemia. The left one, normal QRS, 70 milliseconds. Narrow and sharp, indicates normal ventricular conduction. The middle one, LBBB, left bundle branch block, 140 milliseconds. Wide and slurred QRS, look for deep S in V1 and tall R in V6. Right, RBBB, right bundle branch block, 120 milliseconds. M-shaped, QRS in V1, wide S wave in V6. Still wider than normal. Next, let's look at the ST segment and T wave. These parts of the ECG tell us how the heart muscle is recovering after each beat, and are very important for spotting things like heart attacks, ischemia, or electrolyte problems. ST elevation means the ST segment rises above the baseline. According to the American Heart Association, ST elevation is defined as greater than or equal to 1 mm in 2 or more contiguous limb leads. Greater than or equal to 2 mm in 2 or more contiguous precordial, chest, leads in men aged greater than or equal to 40. Greater than or equal to 1.5 mm in chest leads for adult women. All measured at the J point. ST elevation criteria vary by sex and age. This often signals a serious myocardial infarction, MI, called a STEMI, that needs urgent treatment. This ECG shows clear ST elevation in leads V1 to V3. That means there's injury to the front part of the heart, an anterior STEMI. It's an emergency. ST depression means the ST segment is below the baseline. It's a warning sign that part of the heart muscle isn't getting enough oxygen, called ischemia. T waves can give us clues about what's happening in the heart. Tall T waves might mean high potassium or early heart attack. Inverted T waves are sometimes normal in V1, but in other leads they may suggest ischemia or stress. We always need to check symptoms too, not just the ECG. This ECG shows 2 T wave changes. On the left, tall tented T waves suggest hyperkalemia. On the right, inverted T waves may mean ischemia or stress, but can be normal in V1. Always check the patient's symptoms to help interpret. This is asystole, or flatline. There's no electrical activity, no P waves, no QRS, no heartbeat. Confirm flatline in 2 leads to rule out fine ventricular fibrillation. Begin high-quality CPR and follow ACLS protocol. When we observe this type of EKG wave, we must first check whether any EKG leads have become disconnected and confirm that the patient is unresponsive. Let's quickly review what we've learned. A long PR interval means AV block, first, second, or third degree. A short PR interval may suggest WPW syndrome. ST elevation usually means a myocardial infarction, MI. ST depression points to ischemia, low oxygen to the heart. Tall or inverted T waves could mean high potassium or heart stress. And finally, asystole, the flatline, means cardiac arrest. These patterns help guide urgent care decisions. Always correlate ECG findings with the patient's clinical symptoms and history. ECG is only one part of the diagnosis. Interpreting an EKG may seem difficult at first, but once you understand the basic principles and follow a structured approach, it's actually not that hard.